Okay, so let's move on to the 3 new drugs, and I'm going to go through this data quickly because you all know it. FLT3 mutations are quite common in AML, the internal tandem duplication occurring in about 25%, and about 5% of patients have a tyrosine kinase domain mutation associated with a higher risk of relapse and worse survival. A number of drugs have been developed targeting FLT3 activating mutations, and as single agents, these oral medications have led to biologic activity, decreases in blast counts, but very, very few complete remissions with count recovery. We're going to focus on midostaurin, which is now FDA approved for AML with a FLT3 mutation. And it's based on the study conducted led by CLGB, the RATIFY trial. This is an important study, I have to comment here, led by our friend and colleague, Rich Stone. It's a pleasure to know somebody who has changed the standard of care for AML after 40 years. He deserves a lot of the credit working with international investigators and Novartis. So in the study, patients had to be screened centrally within a couple of days. If they had a FLT3 mutation, either an ITD or a TKD, they were randomized between daunorubicin Ara-C induction with midostaurin or placebo, 4 cycles of Ara-C at 3 grams per meter squared with PKC 412, midostaurin or placebo, and then a maintenance. And the midostaurin was given for 14 consecutive days in sequence with the chemotherapy. Here are the doses here. I'll just point out again the dose of daunorubicin, 60, based on a phase 1 study that Rich performed. There was no statistical difference in CR rates. However, there was an improvement in overall survival. I think the best way of looking at this data is midostaurin 51% at 4-year survival versus 44%, with a 23% reduction in the risk of death in the midostaurin arm, and that was a hazard ratio of 0.77. The median survival, a note to the fellows, you have to be very careful about the median survival. 75 months versus 25 months looks incredibly impressive, except when these curves are hanging around the 50% mark, you could see how you get that dramatic difference in median survival. An improvement in in event-free survival as well. And the benefit was seen not only in those with a FLT3 ITD, either at a higher or lower allelic frequency, but also in patients with a tyrosine kinase domain mutation. Part of the data that caused some investigators to wonder, is the benefit of midostaurin truly just restricted to FLT3 ITD positive patients, or is it working through some other mechanism? There was an improvement in disease-free survival, shown here, again statistically significant, with a 4-year disease-free survival rate of 46% versus 37%. And in patients who underwent allogeneic stem cell transplant in first remission, if they were exposed to midostaurin during their initial therapy, they had a superior survival compared to those who did not get the midostaurin, receive placebo. And there's a lot of interest in trying to understand this and questions about whether midostaurin may help induce an MRD negative state, but that's conjecture and we still don't have the data. So I apologize for the trade name in my slides, but I'm showing you the FDA-approved label, and the FDA-approved label has a trade name. Rydapt, midostaurin, is a kinase inhibitor approved for the treatment of adult patients with newly diagnosed AML that is FLT3 mutation positive, as detected by the FDA-approved assay, in combination with standard cytarabine and daunorubicin induction. You can decide how to interpret standard, and cytarabine consolidation. They actually have a limitation on its use, not for single agent use, and we've probably heard a little bit about mastocytosis already. Okay, so that's the first drug that's been added to our armamentarium. Gemtuzumab, first approved for relapsed and refractory AML patients in 2010 based on 3 phase 2 studies. This is a humanized murine monoclonal antibody against CD33 that is covalently linked to a very powerful toxin, N-acetylcholichiamycin. As you know, in 2010, Pfizer withdrew it from the commercial market based on the results of the SWOG study showing that when 6 milligrams per meter squared of gemtuzumab was added to induction chemotherapy, there was no benefit in terms of CR rates or survival, and there was higher induction mortality. Well, that wasn't the end of gemtuzumab. Again, our colleagues in the United Kingdom performed the AML-15 trial, and in this study, they added a single dose of gemtuzumab, just 3 milligrams per meter squared. So again, different than the labeled dose at the time of 9 milligrams per meter squared, on day 1 of various induction regimens. I'll come back to this at the end. The dose of the daunorubicin was 50 milligrams per meter squared for 3 doses. And small print, but I'll just point out there was no benefit in terms of response rates. And this table down here just points out this. There was no benefit in terms of overall survival or event-free survival. But when looking at subsets, they found that in patients with favorable risk AML, those with core binding factor leukemias, there was a benefit and a trend towards a benefit in intermediate risk karyotype. Again, no benefit in unfavorable. The French Alpha 0701 study looked at a combination of a fractionated dose of gemtuzumab, 3 milligrams per meter squared for 3 days during induction in older AML patients. This fractionated dose was evaluated based on some preclinical data showing that CD33 can be internalized but then rapidly re-expressed on the surface of blasts after exposure to gemtuzumab. So a way of constantly re-exposing the leukemic blast to the drug. So in this randomized trial, patients received between 50 and 70, received 60 versus 200 with gemtuzumab and then consolidation. And you could see there was no difference in response rates, but improvement in event-free survival and also overall survival, although it was less obvious. The British, again, did a study in older AML patients of daunorubicin RAC with or without gemtuzumab, no difference in CR rates, but a statistically significant improvement in risk of relapse and overall survival, again, apparently limited to those patients who had the favorable risk karyotype. And then this meta-analysis, a benefit of gemtuzumab with chemotherapy, especially in the favorable and intermediate risk group, not the poor risk group. So here's the label for Mylotarg, adults with newly diagnosed CD33 positive AML. No mention about with or without chemotherapy, and adult and children with relapse refractory. Finally, CPX351. We'll probably hear more about this from Farhad Ravandi later, so I'm going to dispense with this slide. It's a liposomal daunorubicin cytarabine combination. It was studied in adults between the ages of 60 and 75 with high-risk disease defined as therapy-related to MDS or CMML, or an MDS-like karyotype. One of the potential criticisms of the study is that they were randomized between CPX351 and 7 and 3, and then they got 2 and 5 chemotherapy or CPX351 during consolidation, not HIDAC. There was an improvement in response rates, both CR and overall response, with CPX351. There was less mortality, both at 30 days, lower mortality, both 30 days and 60 days with CPX351. This was due to, there was no difference really in toxicity. There was a difference in deaths due to progression. There was an improvement in survival, shown here. And in patients who underwent allogeneic transplant, there was a benefit. So here's the label for VYXEOS, liposomal daunorubicin cytarabine for newly diagnosed therapy-related AML and AML with myelodysplasia-related changes. Here are our challenges. There's no age limitation, so we don't have data from a randomized trial in younger patients. It allows types of MDS-MPN other than CMML, like juvenile CMML, atypical CML, and refractory anemia with ring sideroblasts and thrombocytosis, the other MDS-MPNs. I think one of the most important things here is it allows patients who have AML with MRC only based on the presence of multilineage dysplasia. And if you're really applying the WHO criteria, before you can make this the diagnosis of either of those things, you have to know karyotype and you have to know genomics because it's a hierarchical system. There are studies using uniformly intensively treated patients with and looking at the value of the MRC-related changes. Patients who had multilineage dysplasia alone did much better than those who had myelodysplasia-related changes with the other categories. Recently, part of the reason for this has been elucidated. If you have a nucleophosmin mutation, you can have multilineage dysplasia. About a quarter of patients did so in this data set, and there was no impact of multilineage dysplasia in that more favorable risk genomic group. So here's the definition that we have now of myelodysplasia-related changes, MDS, myelodysplasia-related cytogenetic abnormalities, and at least 50% of cells in two lineages having an except if they have an NPM or biallelic CBP alpha mutations. So here's my conclusion. Is this where we are? Is 3 and 7 gone? And what we really should be doing is taking a history, prior leukemogenic therapy. You can discuss with yourself, does that mean any kind of radiation? Does that mean any kind of chemotherapy or immunotherapy? It's a little vague in the WHO book. An antecedent MDS or MDS-MPN. And then you need to know cytogenetic risk, and you have to know at least the FLT3 mutation status. And if you want to give CPX-351 to patients with myelodysplasia-related changes who are younger, I would say you really need to know whether they have nucleophosmin or CBP alpha mutations. But what it might come down to is that clearly if they have a FLT3 mutation, we now are using daunorubicin RC with midostaurin. If they have secondary AML or poor risk karyotype, regardless of age, you can consider CPX-351. And if they have good risk disease, maybe daunorubicin RC with gemtuzumab ozogamicin. And I'm not even getting to the post-remission treatment part. So I'm just going to finish with what are our challenges now. So, and I'm just putting this up as a straw man's, model for how we should be treating it. But here are the problems. It requires rapid availability of the results of karyotype and FLT3 mutation status. We need to push our pathologists as clinicians, saying we need this data, and whether it's by a FISH panel or a quick look by a cytogeneticist at a metaphase karyotype, we need the data quickly, and we need the data on FLT3. If a cooperative group trial done across the Atlantic Ocean can get us back FLT3 data within 2 days, so can our commercial laboratories. We really still don't know. I'm sorry, I got to laugh at this. We don't know the optimal dose of daunorubicin when we're going to combine it with GO or midostaurin. In fact, you can argue if those studies were done with a higher dose of daunorubicin, for example, the MRC trial used 90 instead of 50, would there still have been a benefit of GO in the CBF translocated patients? Same thing with midostaurin. This assumes that patients will not have features suggestive of therapy in 2 different groups, and we have no data on the combinations of any of these 3 drugs that have been approved. And then the last 2, do the benefits that we have seen, and you've all seen the event-free survival and overall survival curve, so you'll make your own decision. Do these interventions justify the added toxicities, prolonged cytopenias that have occurred with gemtuzumab ozogamicin, that occur with CPX-351, the risk of VOD and SOS with, I'm sorry, that's supposed to be GO, and the GI toxicities that many of my patients report while taking midostaurin. And then my final point in the plea to all of pharma that is in this audience. Do the benefits of these interventions justify the added cost? What you need to realize is that CPX-351 and gemtuzumab ozogamicin are given as part of induction regimens in the hospital, and many of us are paid based on DRG payments. We cannot eat up our entire DRG payment with the cost of these drugs. These patients are incredibly ill. And if we don't fix this, many clinicians are going to be considering giving the induction chemotherapy in the outpatient setting to avoid the DRG issue. But we don't have data on how safe it is to give these inductions. Over 95% of patients who got CPX-351 in that randomized phase 3 study got it in the hospital. So these are major issues that are confronting us. I don't have the answers, but I look forward to the debate and discussion to begin. Thank you.